Um, so I'm Alan Shoham, and I'm an interventional pain doctor. And I'm an anesthesiologist, and I'm also board certified in pain management. So my practice is pretty much dedicated to just treating chronic pain using interventional techniques. And I'm one of the co-founders of Apex Spine Institute. Me and my partner, Dr. Sahota, who's an orthopedic spine surgeon, are the two owners, and I'm the medical director of the program there. So a little bit about our practice. I think we've been in the community here for over 12 years now, and for about 10 years we were with Tri-Cities Orthopedics, and about a year ago we had focused our practice primarily for spine. So we had separated and kind of have a separate business entity now. And a little bit about our practice. So we have a comprehensive pain management program. We, of course, do interventional pain management. That's my specialty. And we have Dr. Sahota, who's my partner, who's an excellent spine surgeon. And we have a total of 7 medical providers. We have 2 physicians, 2 nurse practitioners, and 3 physician assistants. Dennis Eng is a nurse practitioner that recently joined with us, who's doing our medical pain management. And one of the other physician assistants that are here today, Karen Nguyen, that works with me. And we have X-ray as well as an MRI scanner. We have an imaging center, and we have an outpatient ambulatory surgery center. So for my interventional procedures, I do that all in the surgery center, and we also do spine surgery. We have 23-hour overnight stays, so we're doing more complex spinal surgeries in our center. We recently obtained an actual robot that are in the hospitals as well. So we have the ability to do robotic spine surgery now. It's just, pretty impressive, actually. We're actually the only ambulatory surgery center in the United States of America, technically, that owns outright one of these robots. So it's pretty exciting. We're really providing good, in my opinion, really good care in the community here. And I just want to let you all know that we are open for new patients for medical pain management. This is a part of the practice that we recently started back up. And we have Dennis Eng here, who's an excellent nurse practitioner with a lot of experience in treating chronic pain, and he's spearheading our medical management program. So if you do have patients that need chronic opiate management, we can help take care of those patients. A few questions for the audience. Our talk is on diabetic painful neuropathy and spinal cord stimulation. And this is a common thing. I just want to ask you all, who here has patients with diabetic neuropathy? Just show of hands. Good. It's a pretty common condition. And who here has treated patients with medications for their neuropathy? Okay. All right. And the next question, and one of the reasons why I'm here, is I want to know, and just be honest, who here has ever referred a patient to talk about spinal cord stimulation for painful neuropathy in their feet? Perfect. That's what I was looking for. So it's worthwhile that I'm here, because what I want to do is really convince to all of you that we have really the most effective treatment for painful diabetic neuropathy and spinal cord stimulation. And I'm going to go over some of the data with you today. It's a newer treatment option that many providers are not aware of. And I really want to reach out to all of you, as well as our patient population, because there's a lot of patients suffering with this pain condition that we can really help. So objectives for this talk is just to understand that painful diabetic neuropathy is a progressive and debilitating disease. Many of our patients, they're suffering with just medical management alone. Spinal cord stimulation, it's safe, it's effective, and it's proven to give long-term symptomatic relief, and we're going to go over that. It can reduce pain, it improves patients' mood and sleep, and there's a very high patient satisfaction rate. And I want you all to really start considering part of your treatment algorithm for these patients. And I know the algorithm's it sucks. I mean, these patients, they're miserable. There's not much we can do for them. There's certain medications. Most of the medications that we prescribe for this either don't work well or they stop because of side effects. And there's no other treatments after that. And I want you to let you all know that we do have an effective treatment out there that we can use for many of these patients. So a little bit about painful diabetic neuropathy. As you all know, most of our patients are diabetic. There's about 37 million Americans that have diabetes. And 20% of diabetics end up developing painful diabetic neuropathy. So there's a ton of patients with this condition. Distal symmetrical polyneuropathy, it's kind of a long name, but this is the most common form of diabetic neuropathy. And you can use this term synonymously with diabetic neuropathy. Over 90% of diabetic neuropathy is this distal symmetrical polyneuropathy. Diabetic neuropathy, it leads to gradual loss of integrity of the longest nerve fibers. So symptoms, they typically begin distally. They usually start in the toes and feet and migrate upwards. Symptoms include numbness, tingling, neuropathic pain, again, starting in the toes and feet, and the symptoms migrate more proximally in a stocking distribution. About half of the patients with diabetic neuropathy develop painful diabetic neuropathy. And here's a key point. So half of the diabetic neuropathy is numbness in the feet. And if they have numbness in their feet, but they're not having pain, there's really nothing that we can do about it, frankly. There's medications that can be used, but the medications are primarily for the pain. They're not really for numbness. And there's nothing so far, with this exception I'll talk about later, there's nothing that's been shown to reverse the sensory deficits. Again, half of the patients that have diabetic neuropathy, they develop painful diabetic neuropathy. And that painful diabetic neuropathy, that's what's making them miserable. And that's really what we're treating here. So if patients don't have pain and they have numbness in their feet, we don't want to really treat it because there's no treatments that have been shown to be beneficial. Besides, of course, adequate foot care, you want to make sure that these patients don't develop ulcers and that sort of thing. So painful diabetic neuropathy, again, it's a progressive condition, extremity pain, paresthesias, burning, shooting pain. It's typically worse at night. I've never met a patient with diabetic neuropathy that has a good night of sleep ever. Like the nights are miserable. The most common pain complaint is they can't sleep. They have that burning in their feet. And this is something that spinal cord stimulation works really well for. The therapies for painful neuropathy, it targets pain management. So there's pain medications and there's glycemic control. We want to optimize their blood sugars, and that's thought to mitigate the progressive nerve damage in their feet and legs. Currently, there's no known disease-modifying treatments. It's a progressive condition, can be debilitating. The extremity numbness, it increases the risk of falls. And again, when you lose that protective sensation in your feet, they're at risk of developing ulcers, amputation, and ultimately, these patients can die. So when we look at the conventional medical management for painful diabetic neuropathy, the typical first-line agents are the gabapentinoid medications. So we have gabapentin and Lyrica or pregabalin. There's also some serotonin norepinephrine reuptake inhibitors such as duloxetine and venlafaxine, also known as Cymbalta and Effexor. Tricyclic antidepressants can also be used, a little bit of a tougher side effect profile. And sometimes refractory pain symptoms are treated with opiates, although that's controversial. When we look at the analysis of how well these medications work, we see that they don't work that great. So a meta-analysis of randomized controlled trials of neuropathic pain found that the number needed to treat to get one patient 50% reduction in pain ranges from 4 to 11. So just think about that. You need to give 4 to 11 patients these medications to get pain relief of 50% in one patient. Okay, so these are not slam dunk medications. The other thing to think about is, although when these medications came out, like the Lyrica and the Cymbalta for neuropathic pain, the studies that were done were up to 12 weeks. So these are not long-term studies on these patients. As you all know, because I'm sure you prescribed it, gabapentin and Lyrica, they're commonly prescribed, but long-term adherence is poor. Over 60% of patients, they end up stopping their medications by 6 months, either due to side effects or because it doesn't work. Duloxetine or Cymbalta has a very similar pattern. About half of the patients stop it by 6 months. And ultimately, there's 2 reasons why people stop these medications. Either it doesn't work or they're getting side effects. And most of these patients, ultimately, when they try these medications, it doesn't work. They don't really switch to another regimen, and they just have this untreated pain. And so a large part of our patient population is suffering here. and they've been told up to this point is it's going to get worse. There's nothing we can do about it. We have a few medicines that'll make you, that may help with the symptoms, but that's pretty much it. And I'm telling all of you here today that we do have something else, and it works much better than these medicines when we look at the data for it. So let's talk about spinal cord stimulation for painful neuropathy. It's effective in treating painful diabetic neuropathy refractory to medication management. And basically what I do is place leads in the epidural space, and we stimulate the spinal cord electrically. There's a lot of different mechanisms of action of spinal cord stimulation, and we'll talk a little bit about that. And the way you can think about it is spinal cord stimulation is kind of like a medication, okay? And what we're doing is we're titrating that medication by adjusting the amplitude of the stimulation. We can adjust the pulse width, we can adjust the rate, and we can also adjust which electrode we're stimulating along various segments of the spinal cord. So we have all these different tools to use this electrical stimulation to augment patients' pain. And so I'm going to show you a quick video here. It's from the Nevro company, and I think if they do a good little animation here, that's worth looking at. So let's see if I can figure out how to get this started.
Chronic pain can arise from numerous conditions and have many negative impacts on a person's life. Hyperactivity of the wide dynamic range neurons, or WDRs, which project pain signals to the brain, is believed to contribute to chronic pain. The goal of spinal cord stimulation is to suppress this neural hyperactivity and therefore reduce pain signaling to the brain. Treatment for chronic back and leg pain includes the use of traditional spinal cord stimulation, SCS, in which dorsal column fibers are targeted to reduce pain. Traditional SCS delivers strong low-frequency pulses to activate these dorsal column fibers, generating paresthesia, a tingling sensation that must cover the patient's painful area. Obtaining and maintaining paresthesia coverage for back pain can be difficult, leading to poor long-term outcomes. 10 kilohertz therapy has been uniquely developed as a more efficacious and paresthesia-free therapy. Rather than stimulating the dorsal columns, it is believed to work by more directly targeting the dorsal horn, using consistent lead placement proximal to the painful spinal segments and a high frequency of 10 kilohertz. The result is greater neural inhibition and thus greater efficacy. These frequencies all achieve only 50% responder rates or less, suggesting they cannot achieve the same levels of neural inhibition as 10 kilohertz therapy. Preclinical research into neural inhibition has shown 10 kilohertz stimulation can drive inhibitory neurons without meaningfully activating the excitatory neurons at clinically relevant intensities. This unique ability to selectively drive inhibitory neurons is not observed in testing of 1,000 hertz or even 5 kilohertz. This unique mechanism of 10 kilohertz therapy is believed to be the reason for improved long-term efficacy versus all other SCS therapies. Looking forward, 10 kilohertz therapy's unique mechanism may also provide the versatility to more successfully treat more pain areas and new indications.
Okay, so there. I'm not real tech savvy, so bear with me. I may need someone to help me get back to where we were. Oh, never mind. I did it. Okay. So again, I'm not paid a paid employee, or I'm not paid by Nevro. I don't represent them at all. But what I'm talking about, Nevro, I know they're here and they have a little booth, but I'm speaking highly of Nevro because of this technology that they have and because of the data that's available. And it really works much better than these other ones. So can you move it up?
Is that going to work or not?
If
But
you
I can
can,
get it
can get
completed.
it out of the screen. That'd be
Yeah,
great.
let's just try it. Oh, and ta-da,
Great.
have to get rid of this one. And be brave.
Um, Okay, perfect. Thank you. So a little bit about the different types of stimulation. And I put that video in there because I think they did a pretty good job of giving an introduction to spinal cord stimulation and some of the technical aspects, and they have nice pictures. So doesn't look like this is working.
That's just a space bar, whatever
Space bar.
any of these buttons. It's just the strangest thing when you're monkey. Now try it.
Yeah, it seems to be frozen here.
Sometimes it does some strange things. What's to do with that? Okay, let me go get Melissa. She's the wizard.
Didn't play the video, huh? Okay, you did it. Great. Okay, so low frequency stimulation. So traditionally, and this is what we did, and I implanted all sorts of stimulators. Every company, we've used everything that's worked over the past 12, 13 years. And we started off with this low frequency stimulation. And what you do is you put the leads in the epidural space and you stimulate the dorsal column with this lower frequency, and it creates this paresthesia or buzzing in the patient's painful areas. If they don't get the buzzing in the area that you need it, then you adjust the leads until you get those paresthesias. Once you get those paresthesias, you put that's where you want the leads, and you put them in. And the outcomes have not been overwhelming. Although they've been helpful historically, you're looking at like maybe 50% responder rate. And it was very frequent that patients had a placebo effect where they felt the buzzing, and you put them in permanently, and then they're like, yeah, I feel the buzzing, but it's not really helping my pain. I want this thing taken out. So the explants were much higher. With high frequency stimulation, the mechanism of action is different. The efficacy is much higher, and patients like it better. They just don't ask their devices to be taken out. They like it. So with high frequency stimulation, it's paresthesia free. They use 10 kilohertz of stimulation, and it affects deeper in the dorsal horn, kind of like they were talking about. The high frequency stimulation, it stimulates these inhibitory neurons. And what they do is they inhibit these wide dynamic range neurons. These wide dynamic range neurons are thought to be implicated in chronic pain. And by inhibiting them, this decreases some of the painful signals neurologically. So, all right, so how do we test this out? So you have this technology which seems to work well, and what we do is we try it out on patients. The nice thing about spinal cord stimulation is you don't just put them in people, and you kind of try it before you buy it. It's just like a car, right? You want to test drive it and see if it's something you like or not. So what we do is we evaluate spinal cord stimulation therapy over a trial period, and we typically put the leads in for 5 to 7 days. We typically put the leads in on a Monday, take them out on a Friday, and we test it out. During the period, we see how much is your pain relieved? Does it improve your quality of life? Does it improve your functional ability? The magic number for spinal cord stimulation is we want to get at least 50% improvement. That's what we consider a positive responder rate or a successful trial. And if they get over 50% relief with improvement in their pain and quality of life, then they're qualified to proceed to permanent implantation if they choose to. The spinal cord stimulator trial, it's an outpatient procedure. It's done under local anesthetic with a minimal sedation. It's all done sterilely, and it usually takes less than a half hour. It's a pretty minimally invasive procedure for most patients. Here's some images from a spinal cord stimulator trial that I've done. It's all done under fluoroscopic guidance. We use sterile surgical conditions with prophylactic antibiotics. You can see these larger needles placed in the epidural space at a steep angle. And we use loss of resistance technique. It's the same way to enter the epidural space like with labor and delivery, but again, we're using different types of needles under fluoroscopic guidance at a different angle. Once the needle is in the epidural space, we put the leads through the needles and we advance them in the posterior epidural space until they cover the desired levels. And for painful diabetic neuropathy, we really want to cover from the T8 to T11 level. Once we're happy with the lead placement, we see they're on the lateral view, they're in the posterior epidural space, which you can see here. Then the needles are removed and you have these leads coming out of the skin. And we use steri strips to secure the leads onto the skin, and they're hooked up to an external pulse generator. So here's an image of one of the patient's backs that we recently did a spinal cord stimulator trial for painful diabetic neuropathy. You could see, again, that there's just some sterile eye patches we put on top of the steri strips. We sometimes get a little bit of bleeding or oozing there. And these leads are then secured to this external pulse generator that you see here. And the patient's given a remote. They have different programs that they can work through to optimize what type of therapy works best for their pain symptoms. And they kind of work through the algorithm until we can get adequate pain relief. So when we do the trial, if it's successful and they decide to move on to permanent implantation, the permanent implants I do with my partner, Dr. Sahota. The nice thing about that is we are both pretty good at what we do. He's a surgeon, he does the cutting and sewing, and I do the needling. And so I get, it's an outpatient surgical procedure. We usually do it under either sedation or MAC or general anesthesia with somatosensory evoked potential monitoring. And just like before, when I put the leads in, I do it in the same manner. We get the leads in the epidural space using the same technique under X-ray guidance. Then Dr. Sahota anchors the leads to the thoracolumbar fascia, tunnels the leads under the skin to the IPG site, which you can see here above the iliac crest. And there's a little pocket under the skin that this battery sits in, and it's secured in place. So when we look at contraindications for spinal cord stimulation, the big issues with stim is bleeding and infection. And so when you think about that, number one, of course, is uncontrolled psychiatric disorders. We are required by the insurance companies to do a psychological evaluation on all of these patients. I don't think that it's necessary, but this is what we do. If the patient's on anticoagulation and they can't stop, if they had a recent cardiac stent and they can't stop anticoagulation, we can't do a stimulator. It's just too high risk for epidural hematoma. If they have any systemic infections, you don't want to be implanting anything in the spine. You're just asking for disaster. They're coagulopathic, thrombocytopenic. Again, bleeding and infection are the big issues here. So if they're at risk for any of those, we want to really think twice. As far as the risks and complications from spinal cord stimulation, it's a minimally invasive procedure. It's safer than most spine surgeries, but there still are risks. So we always talk to the patients about risk of bleeding, infection, nerve injury. Epidural hematoma is extremely rare, but it's possible. Neurologic injury, extremely rare, but again, possible. So we don't want to go through any procedures like this unless the benefits outweigh the risks. Lead migration is a very common complication. The leads migrate, even though they're anchored into the thoracolumbar fascia, they can still wiggle around a little bit. Usually we can mitigate that by just stimulating along the electrode at different levels once we see where the leads have moved to. Sometimes we'll go in there and need to adjust the leads to get them back into position. Infection for spinal cord stimulation, it occurs at about 2 to 5% in the diabetic population, which I'm going to go into this in more detail. The infection rate was about 5% for the permanent spinal cord stimulators. It's pretty low, but that's still 1 in 20. Some of those patients, you can save the device by doing IV antibiotics. Some of them do need to get explanted. Again, the diabetic study, which we're going to go into in more detail, had about a 5.6% wound infection rate. And again, that's a you would think a higher risk population with these diabetics with a hemoglobin A1C of 10 or less. Their levels for implant was actually pretty high, and their infection rate was pretty similar to the general population, which was pretty surprising. Pocket site discomfort, really common pain complaint after we put these in. Sometimes people have soreness around the battery site. Again, it's not usually a game changer, but it's just a common complaint that we get, especially on thinner patients that don't have too much cushion. Like any electrical device, iPhone, this computer here, there's always chances for technological failures. So if the IPG fails, the electrode fractures, sometimes we need to replace it, but again, that's pretty rare. So there's different types of spinal cord stimulators. There's many different companies. We have Nevro, Boston Scientific, Medtronic, Abbott, just to name a few. The way I like to group them in my mind is really high frequency versus traditional frequency. And there's only one high frequency stimulator, and that's Nevro. And they're very, very wise. You know, they came up with this idea that this high frequency stimulation, it's different and it works differently and it works better. So let's put a patent on it. So what they did is they got a patent that said that essentially they're the only ones that can stimulate the spinal cord at high frequencies. And Boston Scientific tried doing it, and $85 million later, after a big lawsuit, and the court finally found that no, Nevro has the right to this high frequency stimulation. So a deal was made, I guess, between Boston Scientific and Nevro that Boston Scientific can stimulate up to 1500 hertz, but anything above that is Nevro's. So, and what they found is this 10 kilohertz or 10,000 hertz is really what's this magic number and works the best. And so Nevro is really the only company out there that has this technology. And because of that, that's really the only company I use. With the Nevro device, you can also do traditional low frequency stimulation. So some patients enjoy to feel that buzzing or paresthesia, and you can do that with this device, but there's no other companies that can use this high frequency stimulation legally. When we look at painful diabetic neuropathy, there's been a few different studies, and both low and high frequency stimulation have shown to help, but the high frequency stimulation works best. And we'll talk a little bit here about that. So this is a review article that looks at, there were really 3 studies that have been done in this patient population. There was the large Nevro study we're going to talk quite a bit about in just a minute. And then there's 2 other low frequency studies, one done by Medtronic and one done by, I believe, Abbott. And each of them found that their technology helped. It decreased the pain in this population, but the average pain reduction in the high frequency stimulation was much higher. It was about 74% compared with an average of 47% with the low frequency stimulation. And here you can just see there's basically 3 groups. We have the Nevro study, and just take my word for it. I don't want to go in a lot of detail here, but this is just a much better study. Their patient population is much higher. It was done really well. These are much smaller studies here. But Medtronic found about 38% reduction in pain, St. Jude about 57% reduction, again, Nevro close to 74% reduction. So high frequency stimulation really works best for painful diabetic neuropathy. And so here's this trial which was done that really was a game changer, and this is really why I'm here today, is really to talk about this study. Dr. Peterson, who I believe is a neurosurgeon in Arkansas, I believe, she kind of spearheaded this study. This was done, I believe, at 18 US centers. And what they did is they took a pool of diabetics with painful diabetic neuropathy, and they allocated them into 2 groups. You could either get the continued medical management, which most of these patients were on already, or medical management plus the spinal cord stimulator. They followed these 2 groups for 6 months, and then at 6 months, they allow the patients that are just in the med management group, if they're not getting enough relief, will allow you to get the stimulator. Okay, and so that's how they did this. The nice thing about this is they're following these patients out for years, right? So they originally published in JAMA the 6-month data, then Diabetes Care at 1 year, and then they published the 18-month data. And we're going to be going over data for about 1.5 years. So again, when we look at Lyrica and Cymbalta treating neuropathic pain, they studied it for 12 weeks. Here we're talking about 1.5 years data. So the data is excellent. They took 216 patients with diabetes. They each had to have a pain of 5 or greater on the VAS scale. Their A1C needed to be less than 10 and a BMI of less than 45. So they weren't necessarily thin people, but they have to be below 45. And it was done again at 18 US centers, and they were randomized 1-to-1 via a computer to either get med management or get the spinal cord stimulator. And again, at 6 months, the patients that were getting the med management, they were allowed to cross over to the spinal cord stimulator. And as you would think, they weren't getting much relief with the med management. So 93% of them chose to move on to the spinal cord stimulator. So again, let's look at some of the inclusion criteria. They have to have painful diabetic neuropathy for at least 1 year. Patients had to tried medications. They had to have tried at least 2 medicines, one of them being a gabapentin or Lyrica type medicine, and any other medicine. So if they tried gabapentin or Lyrica and either failed it or they're on it and they're still having symptoms, And if they tried anything else, Tylenol, ibuprofen, lidocaine patches, antidepressants, then they would qualify. If they had, again, they need to have pain, right? So it's not just numbness in the feet, but you have to have pain in order to treat this. So you have to have an average pain score of 5 or greater, and they have to be appropriate surgical candidates. Actually, let's just go back real quick. Just here, there's a lot of information on each of these groups, but you can see there was a few type 1 diabetics, but it was largely type 2 diabetics here. Again, many of these patients have had this painful neuropathy for many years. So this is just some of the baseline data. And this is the pain scores, and this is, to me, really overwhelming if you look at what this is. So this is the pain level that these patients are living with, and they've been living with this for years, right? This is after medical management. And you have these two groups. You have, let's see, where did my mouse go? So you have this med management group here, which is the gray line, and you have this blue line here, which is the spinal cord stimulator group. So you can see these patients that got the stimulator, their average pain scores, they dropped a lot. And you can see that their pain scores, it wasn't just a placebo thing, their pain scores maintained throughout for a year and a half. The med management group, that gray line on the top, you can see they didn't get any better with continued med management. So when they were offered the spinal cord stimulator, you can see what their average pain scores went to. This is overwhelming. This is very impressive stuff, right? These are miserable patients. They have trouble sleeping. This is a slam dunk. It's a home run. It really worked really well for the majority of the patients. And that's why I'm so excited about it. For my patients that I've treated with painful diabetic neuropathy, they've all been home runs. It's life-changing for them. So I'm not just pointing this out because this is some off-label thing that we can now treat. This is FDA approved to treat painful diabetic neuropathy, and the results are pretty overwhelming. A little bit about the pain relief here. So looking at this graph, and it's a little bit odd, but each one of these little horizontal lines, they represent a patient, okay? And so there were 142 patients that were implanted. You can see there's 3 or 4 lines going towards the left, which are negative numbers. On the bottom, you have the percent improvement in baseline pain score. I guess I'll just use this. So this is the percent improvement in baseline pain. And here's a 0. You could see there was like maybe 4 or 5 patients that did not have pain improvement that actually got worse. But all these patients had improvement. 50% is the magic number. That's what we call a positive responder, someone that has a successful stimulator. And basically from here all the way up, all these patients had over 50% symptomatic relief. Okay, so again, on the left, 85% responders, and we call them responders, meaning their pain relief is improved by 50% or greater. Okay, that's pretty significant in this chronic pain population. Average pain relief was 73%. Remission of pain, so they define remission of their foot pain if their pain score dropped to a 3 or less for 6 months or greater consecutively, then their pain was thought to be remitting or gone. And nearly 70% of patients had remission of their pain symptoms. Really impressive data. Look at that number needed to treat. You remember what that number was for the medication management? And I'm not saying that we should be doing this instead of medication management. Medications are obviously less invasive, so we should try them first. But the number needed to treat is 1.3. This stuff works great. The medications that you're using, you may need to prescribe that to 11 patients before you get results in 1. The patient reported reduction in dysesthesias. So this diagram on the left, really it's just showing that at their baseline, okay, at the baseline when they started the study, the red shows a higher proportion of patients. So if it's like in that red area, you're talking 80+% of people are reporting, you know, symptoms of cold, burning, tingling, numbness in these areas. Again, the painful diabetic neuropathy, it starts distally and kind of migrates upwards. You can see at 1 year, so at 1 year after implant, the patient reported dysesthesias or significantly improved, okay? This here is really another thing that I found very impressive, and this study was not done to look at this, but they had neurologists evaluate each of these patients at 3 months, 6 months, a year. What the neurologist found is that their neurologic examination actually improved in over 60% of patients, and that was continued throughout the year and a half, which means that This wasn't done to prove that spinal cord stimulation reverses any of the neurologic deficits, but they saw a reversal, and it was mostly in the sensory exam. So either the patient's sensory exam improved as far as the level of sensory deficit or the severity of their sensory deficit. So they actually had a reversal of the sensory deficit, which nothing, to my knowledge, has ever been shown to actually reverse the sensory deficits in this patient population. It's always been thought to be a progressive, worsening neurologic condition that's just going to get worse over time. Quality of life improvements. You can see this here is this BPI DPN number. This is a score that they use to quantify patients' activities of daily living and their mood. And they found that the spinal cord stimulators significantly improved mood and daily activities, and global assessment of functioning. And this is what we care a lot about. Can people do the things they want to do? It was significantly improved. So their baseline and GAF score was around 60 in both of these groups. They got the stimulators and they had a 20-point improvement after getting the spinal cord stimulators. So we've shown that spinal cord stimulation significantly improves their pain and improves their functional ability and improves their quality of life and improves their ability to sleep and function. So it works really well. Quality of life improvement, there's a 61% reduction in pain interfering with sleep. So this is pain interference with sleep. Again, sleep is the biggest pain complaint that I see in this patient population. And just look at this, whatever this PSQ-3 score is how they quantify pain affecting sleep. And you can see a significant reduction with that spinal cord stimulation. And this one right here, this is really why I put this chart in here. This is looking at the 1-year data. And this is patient satisfaction. And now we all treat chronic pain. And how often do you get 92% of chronic pain patients to say that they're satisfied with something? I mean, it's like, you never see that, right? So the patients love this device. So 60% were very satisfied at 1 year after implant. 32% were satisfied. So you have 90%, 92% of the patients were either satisfied or were very satisfied with their implant. 6% were not sure. A small fraction, just 1% were dissatisfied, and another 1% was very dissatisfied. And again, this is a chronic pain population, so they're very happy with this type of treatment. Other observed endpoints, at 6 months, they noted that the opiate usage had decreased in the spinal cord stimulator group compared with the med management group. They decreased or eliminated opiates in 23% of patients versus 8% in the med management. Very small fraction increased their opiate use in the stimulator group versus 11% in the med management group. Hospital visits were reduced over 6 months. There were 7 fewer hospital visits per 100 patients in the high-frequency stimulator group versus the conventional med management group. The big thing after looking at all the data, so there's 3 different articles that came out every 6 months, looking at all the data after a year and a half after implanting these patients. The bottom line is there's significant improvement in the overall quality of life of these patients. Sleep disturbance due to pain was markedly improved by 61%. Subjects experienced substantial, durable pain relief over a year and a half. And I'm not aware of any data showing this type of efficacy for any type of treatment for painful diabetic neuropathy. A little bit about the overall disposition here. Just looking at how the study was done, there was 181 patients that did the spinal cord stimulator trial. Of them, there was a pretty high success rate. 94% did the trial and they found it effective. And ultimately, 85% of those patients moved on to a permanent implant. So you may say, if 94% had a good trial, how come only 85% were implanted? And there's always stuff that comes up in life, and I see this with our patients. We'll do a trial, it works well, and then they have a little chest pain. They go and they get a stent put in, and they have to be on Plavix for a year, right? So they can't get the permanent stimulator, or they're diagnosed with cancer or some other condition. So once you do a trial, just because it works doesn't mean they always move on to the permanent. It's still a discussion with the patient, and they have to go with the pros and cons and make a decision that works for them. But still, most of those patients, 85%, ended up getting the permanent implant. So 154 patients were implanted. The nice thing about this study, they did a really good job of holding on to the data, right? So they implanted 154 patients. You know how hard it is to get a hold of our patients. They changed their phone numbers and all that. They lost only 5% to follow-up. So of the people they implanted, 95% remained in follow-up for the year and a half, so they can get all this data, giving us this information. Of all the implants that were done, there were no neurologic deficits. So there were no neurologic injuries from the stimulator trials or the permanent implants. There were no explants, not one, because the stimulator didn't work, which is remarkable. Again, with low frequency stimulation, many of the patients wanted them out after you put them in. With this high frequency stimulation, it's very rare that a patient wants it taken out. It works well for them. Procedure-related infections, about 5% infection rate. There were 8 infections. 3 of them resolved with antibiotics. 5 of them required explant. There was 3 IPG revisions, an IPG replacement, and a lead revision. So here, the main reason why I have this slide here is just so that you know that this is not an off-label use. Okay, because of the quality of the data that came up from this study, this is FDA approved for painful diabetic neuropathy. You can see that this high-frequency stimulator device has been approved for failed back surgery syndrome, intractable axial lower back pain, and leg pain. We use it for a lot of different indications. We use it for complex regional pain syndrome as well, but it's FDA approved for diabetic neuropathy. Okay. So in conclusion, painful diabetic neuropathy, it's really an undertreated and progressive disease. All right, it leaves many of our patients with debilitating pain. It affects their sleep, it affects their overall function, and we kind of gloss over it when you see patients in clinic, right? It's one of those things that you can't really do much for, and you just kind of move on to the other stuff that you can treat, like their hemoglobin A1C or whatever else you can target. But I'm telling you, with these patients, just ask them about it. Is it making them miserable? Is it affecting their quality of life? Do they want to try, see what other options are available? If they do, this is something that we can treat. And this condition, it's really outside of the patient population I see. When people have painful diabetic neuropathy, they don't go see the spine guy. I see people that have back pain and neck pain. I want to see these patients. I can make a big change in their quality of life. And that's why I'm here today. That's why I'm reaching out to all of you, because this is outside of the typical patient population I see. And this is what you guys see all the time. So my goal is to reach out to you to let you know that this really is the most effective long-term treatment for painful diabetic neuropathy, period. The evidence is there. It works great, and very few people know about it. If they have painful neuropathy refractory to med management, we ask that you consider a referral for a discussion about this procedure. Spinal cord stimulation, it's life-changing. It really affects people in many ways. Some of our patients tear up after we do the trials and get them treated. When they're suffering with this neuropathic pain, it's really, it changes their lives, and that's why I'm here. I hope I can see more of these patients. Please consider a referral to discuss spinal cord stimulation with patients if they've failed conservative treatment with med management. Questions, anybody? They're insurance companies. So this is an FDA approved device. It's the only patient population that you cannot get coverage on is the Medicaid population and the work injury population. So, oh yes, yeah, yeah, yes.
Could you wait on the question, please? Otherwise, the people won't hear it online. Thank you.
Just a couple of practical questions. What's the cost of the what is it called? Nevro versus the other ones? And how long is their patent good for?
Good question. So the costs, and because, we have, with our practice, we implanted all of them, and my cost to purchase the device to implant into patients is pretty much the same across the board. So one device doesn't cost any more than the other. The second question, the Nevro folks are here. I believe it's 2035. Is that correct for the patent expiration? I know they're working hard to renew that patent. That patent's worth billions of dollars. Yeah.
Thanks, Dr. Shoham.
My
Great
pleasure.
presentation.
Yeah.
So since it is a new treatment modality, how long has it been on the market for? Number one, and number two, would it be considered first line therapy, or do you have to pretty much show that you failed medical treatment?
Yeah, so the good question, and is all based on this data. So if a patient has failed medical treatment, meaning they've tried a gabapentinoid and one other medication, if they've had painful neuropathy for at least a year or longer, and their average pain is a 5 or greater, then they would be a candidate, right? And ultimately, I talk with them and I talk about, is it making you miserable? What's your overall quality of life like? Is this something that makes sense for you? And that's a discussion that I have with the patient. And for some people, we decide, you know what, it's not the best option for you. Some people, it's a no-brainer, and they're like, sign me up. Yeah. What was the other question?
On the market?
Oh, yeah. So the Nevro device, this high frequency stimulation, has been out since 2014. So, and I was implanting low frequency stimulators probably up until 2017, 2018. I made a transition to the Nevro product, and I just believe in it more because they did a great job, and not just with this painful diabetic neuropathy, but with the other indications. They've done really good medical studies that have shown their superiority. So, and as nice as these reps are here today, if there's another device that works better, that's what I'm using. And so I really want to give the patients the best treatment that's out there. With this high frequency device, you can still do low frequency stimulation. So it's the best of all worlds right now, in my opinion.
Thank you. One other question. Are you noting any type of long-term complication with the device? Is it pretty patent, or are patients needing to have it removed and replaced in X number of years?
Yeah, so it's a good question. Again, with the high frequency stimulators, we do a lot fewer explants, meaning when we were doing low frequency stimulation, I would say 10 to 20% of them found that it wasn't effective and they wanted it out. With the high frequency stimulation, it's extremely rare a patient wants to remove it because it's not working. How long it works? So in the US, they implanted the first Nevro high frequency spinal cord stimulator in 2014. And that patient, he's a male, he still has that device in, hasn't needed to have the battery changed yet. So they say at about 10 years, you may have to have their rechargeable batteries. So ultimately, when it's not rechargeable anymore, that's when you have to replace it. But it's, I actually spoke with Bryden about this. They has over about 1,000 patients that they take care of that have spinal cord stimulators, and he's seen one battery that needed to be replaced so far. So, but eventually, all technology, it's rechargeable and it will need to be replaced. That's a pretty minimal procedure, though, to have the battery replaced. My pleasure.
Just a
All right.
stretch.
Well, thank you all. It's a
Thank you
pleasure
so
talking.
much.
Yeah.
Appreciate it.